can recognize the student, she can hear the question, but she doesn't know the student's name, so she experiences transient memory loss. So she goes and sees a neurologist. The neurologist then refers her to an oncologist, and the oncologist diagnoses her with glioblastoma multiforme, which is analogous to grade 4 astrocytoma, which is a tumor that's derived from the supportive tissue in your brain. So the clinical picture here is that this woman now has a median survival time of 15 months with chemotherapy, surgical resection, and radiation therapy. So glioblastoma multiforme is a highly infiltrative tumor that, as you can see, it's typically presents with this butterfly effect where it moves from one cerebral hemisphere to the other. And the biggest issue with tackling this tumor model is the blood-brain barrier. So the blood-brain barrier is a series of tight junctions that protect the blood vessels that move through the brain from foreign substances. So 97% of chemotherapeutics cannot get through this blood-brain barrier. So that presents a big problem because you have, so the current indicated treatment is temozolomide, which is a therapy that has some propensity to cross this blood-brain barrier. So that's the issue that we wanted to face in terms of the clinical picture. So the background. So what I'm going to be talking about is the use of nanoparticles, specifically liposomes, in delivering drug across this blood-brain barrier. So what we see here is in tumor vasculature, you can imagine tumor as a mass of cells that's growing uncontrollably in your body. So as it grows and grows, it suddenly needs nutrients to supply itself that's more than the interstitial fluid or whatever it can get from the body. So it goes through a process called angiogenesis. Angiogenesis is where the tumor secretes something called vascular endothelial growth factor. This is pretty terrifying. It actually allows the host to feed blood vessels and grow blood vessels from the host to supply that tumor. So that tumor can then grow larger and larger. Now the one thing about those blood vessels is that they're very leaky. They're poorly formed from a histological perspective. So what you have is an amount of interstitial fluid that's leaking at the site of the actual tumor. So the theory with nanoparticles is if we can inject a therapeutically relevant particle into the bloodstream of these patients, then they will accumulate at this point of leaky vasculature at the site of the tumor and take effect there. So the background. So what is a lipid nanoparticle? Essentially, all of our cells are made up of lipids. And those lipids include cholesterol, and as was mentioned earlier, there's DSPC, which is a big component, disteroyl phosphotylcholine, which is one of the ones that we use, DSPG, various derivatives. So the beauty of a liposome is that when you take these lipids and you rehydrate them in an aqueous medium, so with water or water-based buffer, they'll spontaneously form these structures that resemble empty cells. So they're like little artificial structures there, and they're highly stable. And what we did in our study and my work is I loaded certain drugs that we believe will have a potent effect on these cells into these liposomal structures. So I'll just go over the methods a little bit. So what we do is we have these liposomes that we form, and we place them in a buffer. And then we add our drug to that buffer, so it's outside of the liposome. So as you can see, there's empty liposomes in that second panel. And if we raise the temperature, suddenly you have these heads of these lipids that suddenly get excited. So the kinetics of that system increase to a point at which equilibration can happen where the drug solution moves inside of those liposomes. So suddenly at this high temperature, the temperature I use is 65 degrees, you have drug solution moving into those liposomes. And now all you have to do is simply cool those down, and suddenly you have little structures that are locked with drug inside of them that we can then use therapeutically. And there are steps that are done in between to clean those liposomes before we inject them into any sort of system. I'm pretty proud of this. This is a picture of my liposomes here. So this is a scanning electron microscopy. And what we do is we run it through kind of like, you can think of it as a nanoscale sieve that essentially makes sure that they're all about 100 nanometers in diameter so that we don't occlude any small vessels or anything. So what did we do? So this is the drug that I was working with. It's carboplatin. What that does is it's a DNA intercalating drug. So that essentially, or alkylating drug. So that comes into the system, and your DNA is highly organized and highly structured. This drug will essentially go in and make it jumbled up and form cross-links that aren't supposed to be there, so that the transcriptional and translational machinery of the cell can no longer work, and then the cell dies and induces apoptosis. So we developed two stable formulations. and we assessed their distributive properties to address the problem that we saw earlier. So this figure here. So this figure shows a novel loading technique that we did. So one of the problems with liposomal delivery is that it's hard to get drug inside and hard to get therapeutically relevant amounts of drug inside. So what we did is we developed this ethanol loading technique where once we're heating up those liposomes and we started adding small amounts of ethanol, we suddenly noticed that we're getting way more drug coming into the cell, into those little liposomes, up to the point where we're getting a drug-to-lipid ratio of 0.2. So you don't have to particularly follow the drug-to-lipid ratio, but that 0.2 as a baseline, some previous studies have reached the level of 0.05. So we're getting 0.2, which means that once we start getting into treatment of these issues, we can have much higher doses at much smaller volumes, and that's just a much more efficient system. So what I did essentially next was I took those loaded liposomes and I just wanted to see how stable they were. So I let them be, and essentially they're pretty consistent over time. And so this means that when we move into possibly manufacturing or anything of that sort, there will be an ability for us to store that drug. Now this is the best figure here. So I initially told you that there's this problem that we're facing with distribution of drug to the blood-brain barrier. And the way that I introduced that is that we want to increase the amount of time that the drug is in circulation in the body to promote that probability of it being leaked into the site of the local microenvironment of the tumor. So how can we assess that? So this is a plasma pharmacokinetic profile of what you see here. So this figure, the top left small plot, is if you just inject intravenous carboplatin, you see that it decays rapidly. So after 1 hour, you have almost minuscule amounts in the body. Whereas if you look at our two formulations here, which I won't go into the details about those two formulations, but those two over there, you see that by 10 hours, you still have more drug in the body than if you have just the free drug. So that's summarizing this plot here. So you see the half-life goes from 0.7 to about 15 hours there. So what this means and what we hypothesize from these results is, okay, so now we're seeing more drug available in the plasma. Is that translating based on our theory and our body of knowledge, is that translating into more drug in the actual brain tissue? So, okay. So now I'm going to talk through these results because our lab does a lot of patenting, and so I can't actually show you the images yet because they aren't available. But what we have is we have the pharmacokinetic profiles of brain tissue. So we did the exact same thing, and we looked at the amount of carboplatin in the brain. And what we see is an increase in the amount of carboplatin in the brain. And so the next step was to then implant orthotopic tumors. So what we did is we took U251, which is a cell line of glioblastoma cells, and we put those into the brains of mice, and we cultivated those tumors. And through that, we actually showed that the efficacy of treatment with liposomal carboplatin is much better and improved compared to the treatment of free carboplatin. And so the translational potential of this study is also into lung cancer. So we were talking to a specialist, so some of the work I'll do this summer is going to be looking into this potential in lung cancer models. So I just want to go back and revisit the story that I told you at the beginning. So with one of the things about cancer therapy and chemotherapy of highly aggressive tumors is that the toxicity is almost worse than the actual disease. And what we do with these liposomes is we're protecting the body from seeing the drug in non-therapeutically relevant areas. So we're promoting the distribution, we're prolonging that time, increasing the probability that it'll accumulate at the tumor, but we're proposing that that will reduce toxicity systemically. And that's what we saw in our mice population, and that's what we hope to see as we move on with the studies. So I could not have done any of this work. Marcel Valley is just a phenomenal guy, and Mo, Malafi, and Ian are all great people in our lab, and these are just some interceptions. Thank you.
Hi, great talk. So I was just wondering, we talked about the applications of these nanoparticles in brain and possibly lung cancer. I was just wondering, how can you make sure that these nanoparticles are releasing the drug at the right tissue? Like, is there a method or?
So what we do there is that's partly the leap that you make when you move into an orthotopic tumor model. So ultimately, we're testing the amount of carboplatin. So we use atomic absorption spectroscopy to find out the amount of platinum in the tissue that we actually test. So that essentially, because so our drug there has one platinum molecule, or one platinum atom per molecule of drug. So what we can do is we can correlate the amount of platinum that we pick up to that. But in response to your question, when we see an effect in the actual brain of orthotopically treated mice, that's when we can then make the connection and say that, okay, drug is being delivered, or there's some sort of therapeutically relevant outcome there. I wish I could have shown the figure, but I was trying really hard, but I couldn't today, unfortunately. Yes?
Have you determined the drug to lipid ratio?
The drug to lipid ratio, okay. So that's a metric that's used in liposome work, and so essentially you want to quantify the amount of like the efficiency of your loading. And so if you have a liposome with not very much drug, that's kind of correlated in the drug to lipid ratio. So the way that we did that, I kind of mentioned the atomic absorption spectroscopy. So we take a sample that we've taken out and we put it through atomic absorption spectroscopy, which essentially heats the sample up to ridiculous temperatures, and you get the spectrum of the heavy metal that's in there, or the metal that's in the sample, and then that'll correlate to the concentration of that. And in terms of the lipid, every time we make a batch of liposomes, we actually label it with radioactive cholesterol. So we use tritium-labeled cholesterol that incorporates into the membranes, and based on the specific activity calculations, we can then get the amount of micromoles of lipid itself to make the drug to lipid ratio.
You said the temperature affects the permeability of liposomes. So is it possible that on a hot day the drug can leak?
It's technically possible, absolutely. But so there's a couple things with that. So the first is that first of all, you'd be storing the drug in a fridge, and so most of my long-term stability has been in 4 degrees Celsius temperatures. So those, in that case, is pretty stable. But when we're doing this, it's actually at 65 degrees that we're so it's literally submerged in a hot water bath at 65 degrees Celsius. So that would be quite a hot day that would have to do that. And the last thing that's actually I should have probably led with is that even if the drug leaks out, carboplatin is still a chemotherapeutic agent that is indicated for treatment of some sort of illness. So if you're getting a little bit of drug leaking out, that's still okay, because when you administer that bolus injection, you're still giving a therapeutically relevant drug. Yeah.
So that the site was one of the tumors, and there's new blood vessels being built to supply the tumor. When this drug is going and leaking out, how does that affect the other tissues that are healthy near that area?
So at the end of the day, these drugs are affecting highly rapidly dividing cells. So that's kind of the fundamental kind of foundation of cancer chemotherapy and chemotherapeutics, is that you want to hit cells that are dividing rapidly.
Yeah.
So we do propose that, and I completely agree that there will be some kind of collateral damage in that region. But by localizing it to the regions of leaky vasculature, you're really isolating the other parts of the body. So for example, when you see GI problems, it's because the drug is hitting all dividing cells. So like, for example, your mucosal lining is dividing rapidly because there's rapid turnover. So that's why there's a lot of nausea and vomiting side effects of cancer chemotherapy. Whereas this, we